Hey, Dr. Tutkar, Dr. Gautam, and Dr. Rishi. So, in this session, let me brief you about a case, and we will have a comprehensive clinical examination done from you. This will be a part of mini clinical examination along with teaching and learning process. Simultaneously, it will go on. Not rigidly, it will be a mini clinical examination, everything burdened on you. I will cooperate and I will enter in between. We will talk in between whatever clinical findings are there. So let me brief you about this case. This 45-year-old male is having diabetes mellitus since 15 years. He has been neglecting his treatment. He was on insulin prescribed, but intermittently he took insulin and he presented to us with complaints of tingling and burning sensation which started from the lower limbs and it is gradually ascending up to somewhere below knee, mid-leg portions. And he is also complaining of difficulty in getting up from squatting position. And with this brief review, if you analyze this case with this symptom, it is pretty sure that this is a case of peripheral neuropathy. But we will delve into the clinical examination of peripheral neuropathy and what are the other pathologies as far as neurology is concerned in diabetes. We will go on as our examination goes on, and I will help you intermittently in between. So we start with the neurology examination, higher functions. So higher functions are intact?
Higher functions are intact, sir. Speech was normal, patient is conscious, well oriented to time, place and person. Graphic reasoning is intact and calculation is also intact, sir.
Okay. Conscious oriented, alert, responding well to questions, calculations normal, speech normal, abstract reasoning normal, judgment normal, everything is normal. Coming to cranial nerves. Keeping a scenario of diabetes and cranial nerves. As per protocol, ideally all cranial nerves should be examined, but which cranial nerves we will specifically concentrate on in the case of diabetes?
I would like to concentrate on 2nd, 3rd, 4th, 6th and 7th cranial nerve.
Very good. 2nd, 3rd, 4th, 6th and 7th, because isolated craniopathy is a part and parcel of diabetic neuropathy. So when we go for 2nd cranial nerve test, have you done the visual acuity?
Yes, sir. Visual acuity was intact.
Intact. Color vision?
Color vision was intact, sir.
Intact. Field of vision confrontation test?
It was adequate, sir.
It was adequate, no hemianophilia. Now coming to the pupillary reflex. So ideally one should always check for the pupillary reflex, and fundus examination should be done. Fundus examination has already been done. Yesterday we did it, and there was background retinopathy. And let us talk about the pupillary reflex. Go ahead with the pupillary reflex.
आगे सीधे देखना है. Pupils are 4 mm and constricting to light.
So bilateral pupil are
Reactive to light.
reactive to light 4 mm. Okay. So pupillary reflex is normal. So in this patient, the 2nd cranial nerve is normal. What are the afferent and different of pupillary reflex? Afferent is the 2nd cranial nerve and different is the 3rd cranial nerve. Now we go for the 3rd, 4th and 6th simultaneously as far as ocular movements are concerned. Can you demonstrate how to do that?
काका बोर्ड को देखना है, ठीक है? सर नहीं हिलाना है. Eye movement is adequate, sir, in all quadrants.
Very good. In all quadrants, ocular, extraocular muscles are intact. So 3rd, 4th, 6th done. Superior oblique, inferior oblique, all recti are intact. Here comes the important aspect. Dr. Gautam, can you comment on the craniopathies what we are talking of? We have already answered the questions. All these cranial nerves can be involved. As far as 4th, 6th are concerned, it will be detected fantastically, like there will be ocular movement will be restricted. We can come up with the answer that which cranial nerve is involved. I am specially interested in 3rd cranial nerve. So is there any speciality? There is specific 3rd cranial nerve paralysis in a diabetic person, theoretically speaking. and third cranial nerve palsy in a non-diabetic subject. Is there any difference? Can you answer? Can you answer?
Sir, in diabetics there is pupillary scarring because the nerves of the third cranial nerve that supply the pupil are peripherally placed. So they are not involved in diabetes or any vascular disease. While in other diseases there is involvement of the peripheral.
Very good. When we talk of a complete third nerve palsy in a non-diabetic situation, as we know, the three pillars of third nerve palsy will be: the eyeball will be displaced laterally and inferiorly because of the unopposed action of the lateral rectus and superior oblique muscle. And secondly, there will be ptosis because of levator palpebris superioris paralysis. And thirdly, the pupil will be mydriatic. There will be dilatation of the pupil. But in the case of diabetic third nerve palsy, we will get a scenario like this. All other components will be like that. Ptosis will be like that. Eyeball will be shifted down and out. But the pupils will be spared, as Dr. Utkarsh answered, as you answered, because in the motor nerve, in the nerve trunk, the oculomotor nerve, the pupillary fibers are peripherally situated. And the vasa nervosum, the small vessels which are supplying the oculomotor nerve, they supply the middle part of the trunk. And due to vasculitic changes in the diabetic patient, these small vasculitic changes, the damage will occur in the central part of the oculomotor nerve trunk. And the pupillary fibers are periphery, they are in the periphery, so there will be spare. So, to conclude, in diabetes mellitus, there will be a pupillary sparing third nerve palsy. All other cranial nerves are intact. Okay. ऐसा करिए ऊपर. Very good. So, frontal vilio proximal frontal is normal. आँख जोर से बंद करिए. हवा भरिए थोड़ा मुंह में. ठीक है. व्हिसिल मारने जैसा करिए. ओके. दांत दिखाइए टाइट. टाइट और टाइट करिए. हाँ. So, facial nerve is adequate. On inspection only there was no deviation of mouth, no nasal level for was not plugged, and we examined the facial nerve. So cranial nerve examination in our subject is intact, but we learned that what cranial nerve should be focusedly examined, and pupillary sparing third nerve palsy is an interesting thing that are asked. These questions are asked in the examination in MBBS examinations. Now cranial nerve is done. Now coming to the motor system examination. So in the motor system examination, as our patient had a complaint of tingling bilaterally, numbness and paresthesias ascending up, it was pretty mathematical, it is a neuropathy, but we go for the motor system examination. We have already done it. This is a comprehensive test. We want to just focus on what findings we got. So upper limbs were normal.
Upper limbs are normal, sir. PAR is 5/5 in bilateral.
But as you see, before we go for the whole as a whole in toto motor system examination, look at the patient that he is emaciated. He is thin. He is thin build. Look at the temporal hollowing. Look at the temporal hollowing. Okay. And he is overall thin patient. As we know that diabetes is a situation where there is a hypercatabolic state, hyperglycemia and hypercatabolic state, and this is a systemic inflammatory state, uncontrolled diabetes. That is why the patient is emaciated. So we focus our clinical examination to the lower limbs. As you say, upper limbs are all power of 5/5. Everything was normal. There is no ST and all of things. So if you see here on inspection, let us, before we go to the examination, look at the quadriceps muscle. Come here and focus here. Very simple bedside test to assess quadriceps wasting. Just slide your hands like this. In a normal person, the hands will smoothly go away above the patella and come down like this. There will be no obstruction. Here if you see, my hand is getting stuck on the patella. That suggests there is an indirect relative evidence that this muscle is thinned out. This is important in diabetes mellitus because there is a concept which is known as diabetic proximal femoral neuropathy, and it is also known as diabetic amyotrophy. So this muscle is a targeted muscle, and we will come later on because there was a complaint, if you remember, getting up from squatting position is difficult in getting up from squatting position. So there is a proximal muscle involvement already there. Okay. So nutrition wise, if we start, it looks that the quadriceps muscles are thinned out. Okay. Then tone. Okay. Can you demonstrate how to examine tone, Dr. Rishi?
No, quadriceps.
So tone is, it seems fairly okay because when you just feet like this, the limb is able to sustain the limb. दोनों पाँव मोड़ लीजिए. Okay. ढीला छोड़ दीजिए. Okay, I feel the tone is okay. ढीला छोड़ दीजिए. कोई प्रॉब्लम नहीं, ढीला छोड़ दीजिए. Intermittently becoming anxiety, so we are getting hyper-reflex attack, but it is, the tone is okay. So we go for the power. Okay. Before going for the power, we just come down here and focus on these quadriceps muscles. When we are examining the tone, you can see how thinned out the quadriceps muscle were. See, all the individual muscle bellies are getting prominent. You can see here. Okay, and power. Dr. Gautam, can you go out to power? So we start with hip flexors.
So काका, ये पैर को आपको ऊपर करना है, मैं नीचे जोर लगाऊंगा.
You are directly going for 4. First go with the 3, grade 3 power demonstration. Don't, हाँ, इसको पाँव को सीधा रखना है, घुटना मोड़ना नहीं है, पाँव को ऊपर करना. ऊपर करिए, बिना घुटना मोड़े, पूरा पाँव ऊपर करो. ये हाथ, ये पाँव करिए वैसे. So grade 3 is already done. Now let us see whether the patient is having grade 4.
So काका, मैं आपके पैर पे जोर लगाऊंगा, लेकिन आपको पैर ऐसे ही ऊपर करना है और सीधा रखना है घुटने. करो, ऊपर करो, जोर लगाओ, ऊपर करो.
So नहीं हो पा रहा. तो दिक्कत हो रही है क्या? दिक्कत हो रही है उठाने में? So against resistance he is not able to lift the leg. So power is just grade 3 or just maybe grade 4 minus. Okay, in the hip flexors. Now demonstrate in the knee extensors. Okay, grade 3. We will not touch the patient. We will fix the joint.
पैर सीधा उठाना है.
पैर इसको सीधा ऐसे ऊपर उठाइए और मेरे हाथ पे लगाइए ऐसे.
उठोगे?
हाँ, उठाइए. दिक्कत जा रही है क्या? इसके ऊपर से दिक्कत जा रही है. See, one is the very interesting neurological scenario. When students are asked to demonstrate grade 3 power, you see, till the leg is going up to this, it is not actually against gravity. The story actually starts from here to here because gravity is acting like this. So if you see here, he is not able to do. पूरा मेरे हाथ में लगाए, कोशिश करिए. Now the story starts. दिक्कत जा रही है.
टाइट हो जाता है.
टाइट दिक्कत जा रही है. अच्छा.
ये जो
There is also shortening. There is also hamstring tightness. Okay. ठीक है, सिर्फ इधर से ही ऊपर उठाओ, यहाँ तक. अच्छा, अब उठाओ. So it is grade 4. और जोर से दबा रहा हूँ, उठाओ. It is grade 4. He is not able to extend normal after applying normal powers. उठाइए पहले यहाँ तक. Okay, grade 3 done. अभी उठाइए. Again grade 4 minus. Now coming to dorsiflexors of the ankle. First we will demonstrate grade 3 power in the dorsiflexors of the ankle. Let us, how we will say?
So we'll
we'll
tell the patient to lift the
dorsiflex the ankle. ये पंजा है, पंजा को ऊपर करो. हाँ, उठा दे. ये पंजा ऊपर करो. अभी करो. Okay. Power is 5 here. Power is grade 5 here. Okay. पीछे हो जाइए थोड़ा. पेट के बल हो सकते हैं क्या? हाँ, अभी ये पाँव को बिना मोड़े यहाँ से उठा सकते हैं? नहीं. नहीं, इसको बिना मोड़े यहाँ उठा सकते हैं ऐसा। ऐसा, हाँ उठाइए। सो हिप फ्लेक्सर्स 4-, ये पाँव उठाइए 4-, ओके। ये पाँव ऐसा मोड़िए, अब मोड़ो 4-, अब मोड़ो 4-, ठीक है। ये पंजा को ऊपर करो, ये पंजा को ऊपर करो, अभी ऊपर करो। दिस इज 5, ओके, ठीक है, सीधा हो जाइए। So to summarize our motor findings as far as power is concerned, this was grade 3, this was 4-, normal. Okay, now let us go for the sensory examination. Because coordination and all are intact, we have seen those things. There is no imbalance, ataxia, we are least bothered about the coordination part. Now we directly, involuntary movements, there are no involuntary movements, and gait we will see later on. Now let us jump to the sensory examination. So Dr. Utkarsh, we will start from the sensory examination.
The sensory examination I would be taking a cotton vest. स्पर्श समझ आ रहा है? आंखें बंद करना है और जब भी स्पर्श होए तो हो बोलना है, ठीक है? स्पर्श हो रहा है कब?
होगा तो 1, 2, 3 ऐसा गिनना है।
1, 2, 1, 2,
हाँ, डर्माटोमल डिस्ट्रीब्यूशन गिनना है।
1, 2, 2,
जोर से बोलो।
2, 2,
2 के बाद 3,
3, 4, 5, 6, 7, 8, 9, 10, 11, 12, 13, 14, 15, 16, 17, 18, 19,
ठीक है। He is not appreciating the cotton touch, fine touch in both the feet. Okay, let us go with the pin clip. You will demonstrate with the pin clip. I will examine. ये पिन है ना अपना, ये नोकिला वाला पार्ट है और ये हेड है उसका, मतलब जो नोकिला नहीं है, ये नोकिला वाला पार्ट, नोकिला वाला पार्ट है। ये नोकिला है, ये वाला नोकिला है क्या? दोनों में से कौन सा नोकिला है बताना। आँख बंद करो।
नोकिला,
नोकिला, जोर से बोलना थोड़ा।
बिन नोकिला,
बिन नोकिला। अच्छा, पेशेंट हैज अंडरस्टूड। ओके, जब नोकिला लगेगा 1, 2, 3 जैसे अपन ने वहां बताया था वैसे
1, 2, 3 नोकिला, 3 नोकिला, 2, 3 नोकिला, 3 नोकिला, नोकिला, नोकिला,
जोर से बोलो।
नोकिला है,
नुकीला लगा तो 1 2 3 ही गिनना है अपने।
1 2 3 4 5 6
So again, pinprick is also impaired. Okay. Now let us go for the vibration sense.
Kaka.
Pick this hammer. When you always remember, when you are striking, don't strike on your own body. This is how much? So this is 128. Huh? Start with this. Okay. अभी मैं इसको लगाऊंगा आपका इसमें, सिर्फ रखा है अगर समझ में आ रहा है तो वो हमको नहीं चाहिए, झुनझुनी लग रहा है कि नहीं समझ में आ रहा है ये बताना आप। हाँ, झुनझुनी जैसा लग रहा है ना, लग रहा है तो बताना। अभी लग रहा है क्या?
अभी नहीं।
बंद हो गया? नाउ द पेशेंट अंडरस्टूड वाइब्रेशन सेंस। लेट अस स्टार्ट। अभी जब भी झुनझुनी लगा तो बताना झुनझुनी महसूस हो रहा है कि नहीं। झुनझुनी है तो बताना। लग रहा है क्या झुनझुनी? नहीं लग रहा। थोड़ा ध्यान से। हैं?
नहीं लग रहा।
अच्छा,
नहीं लग रहा। नहीं लग रहा। नहीं लग रहा। लग रहा।
लग रहा है कि नहीं लग रहा?
लग रहा है, लग रहा है।
लग रहा है, झुनझुनी लग रहा है?
हाँ,
लग रहा है क्या?
लग रहा है।
अभी लग रहा है क्या?
वही बात।
बंद हो गई?
हाँ।
हाँ। अभी लग रहा?
हाँ हाँ।
अभी
अभी कम लगी। मुझे दहेज में ऐसा लगा। लगी।
लगी?
हाँ लगी। आने लगी।
Okay. So in vibration examination, grade 2, this joint, metacarpophalangeal joint, medial malleolus, lateral malleolus, up to this there was no vibration sense. So vibration sense is also impaired up to this. Okay. So we have done the sensory examination, fine touch, and let us see whether the position sense is intact or not. इधर देखिए. Can you demonstrate how to go for position sense examinations? Demonstrate.
सुनो काका, ये जो अपना अंगूठा है, ठीक है, अगर मैं आपको ऐसे करूँगा तो ये वर है, ये करूँगा तो ये नीचे है, ठीक है। आप अभी अपनी आंखें बंद।
Again explain him and ask the question. इधर देखिए
काका, इधर देखो, ये अभी के
ऊपर है।
हाँ,
हाँ,
वो नीचे।
ये
नीचे। अभी आंख बंद करके बताना है ऊपर है कि नीचे है।
ये ऊपर।
अब काका,
नीचे।
अब
नीचे।
अब
नीचे।
अब
वेरी गुड, रिपीट हियर।
अब काका,
ख्याल में नहीं डबल।
अभी
ऊपर। नीचे।
अभी
नीचे।
अभी
अभी बीच में दिखा।
अभी
ऊपर।
अभी
नीचे।
Okay. So fairly position sense is intact. Okay. So after the clinical examination, how we will summarize? So definitely it is a case of peripheral neuropathy. Before that, along with peripheral neuropathy, peripheral polyneuropathy, as per history, we know the history now. On examination, we found that there was loss of sensations, cotton touch sensation, pinprick sensation, and vibration sensations bilaterally was impaired, rather lost to this level. And as per the patient, the tingling is up to this level. But our clinical findings, neuropathic findings were to this level. And cranial nerve examination was normal. If I ask you now, with the final diagnosis of a peripheral polyneuropathy, and we will also demonstrate the last part of proximal femoral neuropathy, what is the status of the proximal muscles, so we will ask now. Anything more you want to do in general examination? I am giving you a clue, blood pressure examination.
So for autonomic dysfunction, I checked the blood pressure of the patient in supine position.
You already done that?
Yes, sir.
Very good. What was the status?
Sir, there was a difference of 22 mmHg in systolic blood pressure and 12 mmHg in diastolic blood pressure. There was a fall.
So there was a postural drop.
Postural drop, sir.
So it is a part of autonomic neuropathy also. Okay. So orthostatic hypotension is also a part of autonomic neuropathy. So this patient is having that?
Yes, sir.
Okay. So what was the pulse rate?
Pulse rate was, sir, around 108 beats per minute.
Okay. There was resting tachycardia.
There was resting tachycardia, sir.
Okay. So again, resting tachycardia is a part of autonomic neuropathy also. Okay. So उठेंगे थोड़ा, बिना सहारे का सीधा उठ के बैठ सकते हैं? कोशिश करिए, देखते हैं कितना सहारा लेके उठना पड़ रहा है. देखें,
जमता नहीं वो हाथ
पूरा हाथ लगाना पड़ता है.
हाँ क्या फिर ऐसा कड़ पलट के पैर नीचे पलंगे
अच्छा, उठ के बताइए, वैसे उठ के बताइए. देखें, अच्छा ऐसे सीधा उठ ही नहीं पाते. So this is an interesting thing. The patient is unable to get up from the supine position to sitting position. This also suggests that there is some trunkal involvement also. So trunkal plexopathy is also a part of diabetic neuropathy. You can see the intercostal spaces. Close up here, please. Look at the intercostal spaces here. The intercostal muscles are atrophied. If you see, the ribs are unduly prominent. Okay. Watch for any fasciculation. There are no fasciculations, but you can see the ribs are unduly prominent, and it is likely so the patient is unable to get up from a supine position to sitting position. Abdominal muscles are also laxed. Okay. तो कैसे आप उठते हैं? अगर बताना पड़ता है तो कैसे उठते हैं? उठ के बताइए.
नीचे.
हाँ, अगर ऐसे से आपको बोल दिया गया उठो,
उठो
तो आप कैसे उठते हो? Look at the way he is taking support to just sit from a lying down position. This is one. Second, अगर हम बैठते हैं जैसे लैट्रिन में जैसे बैठते हैं, बैठ के अपने आप उठ पाते हैं क्या?
एक संडास में जो रहता वो पकड़ देना पड़ता है.
हाँ.
एक नीचे हाथ नीचे रखना पड़ता है.
पूरा सहारा लेके.
दो हाथ का सहारा लेना पड़ेगा.
अच्छा, एक बार दिखा सकते हैं क्या? मैं हूँ, आप हाथ पकड़ो. He is also for sitting also he is taking support. Okay. कोशिश करिए उठने की. So look at the way he is getting up. So look at the way he
जो
is
है
getting
नहीं जो लग जाती है.
So look at the way he is getting up and how he described it. So there is also proximal muscle weakness. So diabetic amyotrophy, diabetic trunkal plexopathy, getting up, difficulty in getting up from supine position to sitting position, difficulty in getting up from squatting to standing position, along with all the sensory findings what we got in the peripheral nerve. Only thing is that the motor component is less affected in the distal limbs. Last एक बार उठिएंगे, खड़े होंगे, आ जाइए सामने. बिना सहारे का ऐसा खड़े हो सकते हैं?
ऊँचे भी.
ऐसे ऊंचे. Okay, he is able to do that. So the plantar flexors are there, but still it is a little bit unstable, but he is able to do that. अच्छा, ऐसा खड़े हो सकते हैं, ऐसे खड़े हो, ऐसे, ओके, ठीक है। सो मोटर पार्ट इज ए फेयरली स्पेयर्ड लिटिल बिट। आंख बंद करेंगे क्या? So we are testing the position sense by doing a rhombus test. दो बैठ जाइए, दो rhombus test is very specific for dorsal column, but very rare situation in the peripheral neuropathy. If the large fibers are involved, then there will be absence of rhombus test. Now coming to the another most important part, let जाइए, reflexes. Can you demonstrate the ankle jerk? So ankle is absent.
Absent. Ankle jerk is absent bilaterally.
Okay, ankle jerk is absent. Let us go for the knee jerk.
हाथ छोड़, पैर छोड़. Knee
इसको
jerk
ऐसे
is-
Oh, this is the patellar tendon, yes. हाँ. Knee absent.
Knee
That link.
छोड़ दो.
दांत कड़क करिए, दांत कड़क करिए. लेट अस सी आफ्टर रीइंफोर्समेंट. दांत कड़क करो ऐसे, दांत कड़क. हाँ, देखो फिर से. इवन आफ्टर रीइंफोर्समेंट इट इज नॉट देयर. यहाँ पे फिर से एक बार दांत कड़क करिए, दांत कड़क करो एकदम. After reinforcement there was a little bit jerk here, we could appreciate that was absent. Let us reconfirm last the ankle jerk after reinforcement. दांत कड़क करिए, absent. No, it is absent. So there is loss of reflex bilateral ankle and knee. Mini clinical examination and discussion session. We examined a case of uncontrolled diabetes who presented to us with signs symptoms of neuropathy, tingling sensation. We comprehensively examined how a diabetic neurological examination should be done. Air function was normal. Cranial nerves we discussed. What are the important cranial nerves that can be involved in diabetes mellitus? Then we came down to the motor system examination. We got our findings. There was proximal femoral neuropathy, amyotrophy, and though the muscle power in the distal limbs were little bit intact, the sensory system was abnormal. There was loss of sensation up to mid leg. There was areflexia, vibration sense was impaired. Though the position sense were intact, and the pinprick sensation was impaired. So to conclude, it is a case of diabetic polyneuropathy with proximal femoral neuropathy or diabetic amyotrophy, and there was also trunkal plexopathy. So this patient is having these three diabetic neuropathic along with autonomic involvement.